I'm recording now.
All right. Well, hi everyone, and thanks for being here to the Echo for today, March the 3rd, right? March the 3rd of 2020. I'm going to talk today about, I have to use this. Okay, got it. There are no disclosures from any of us to report. I'm going to talk today about use of sort of pharmacotherapy for opioid use disorders in special populations. And that's going to be the topic of interest today. And as we make this is sort of initially was done, it's been done by several people. A special thank you to Leah Nelson, who's our current fellow in addiction medicine, who actually created this slide set and was the original presenter. Dr. Romo has presented it, as you can see here. He was the last presenter for this. I believe, Dr. Jacobson, you may also have presented this with various versions of this. So I think I'm the presenter du jour for this presentation. So we'll describe the epidemiology of changing addiction among different special populations, describe the selection criteria for buprenorphine induction eligibility, and identify the special populations that should be taken into considerations when treating opioid use disorders with buprenorphine, right? So we'll start with teens, pregnant women, breastfeeding women, and medically comorbid populations are going to be some of the big ones we talk about. We do a whole other presentation, just a matter of note, on treating it in patients with co-occurring psychiatric illnesses. So that's not the focus here, because we have an entire presentation devoted to that. So let's start with teenagers, right? So what is the rationale for medication-assisted treatment? That's, of course, what MAT stands for in this population. So one thing to start off with right off the bat is that American Academy of Pediatrics, AAP, recommends medication-assisted treatments for teens or adolescents, transitional age youth with opioid use disorders. And in fact, one of the things that American Academy of Pediatrics has brought up repeatedly and has been bored through with data, which I'll present here in just a second, is that treatment, pharmacotherapy for opioid use disorders works just as well in adolescents as it does in adults. The way you do it is very similar, and yet the access gap is even larger. And that's been one of the big concerns of American Academy of Pediatrics, and so they have this push of getting more providers trained, more pediatrician trained in prescribing it. It does seem like medication-assisted treatments in this population likely reduce overdose mortalities, along with things like school expulsion and dropouts, arrests and criminal outcomes, and sort of progression of the illness, right? Oftentimes our teenagers are starting out by experimenting with kind of oral opioid medications before moving on to things like heroin or even injecting substances. And the idea is that if we can start treating them now, we can prevent that progression, right? And all the bad things that come with it, such as hepatitis C and abscesses and things, and ultimately, unfortunately, overdoses. It also seems to improve engagement with medical care, right? Our teenagers can sometimes be notoriously difficult in terms of getting them to engage with medical care for a variety of reasons, and especially if they have opioid use disorder, it's even tougher. And providing them this treatment can actually help improve that. And it provides route to engage teens and also family in counseling and other social services, which of course can be very, very helpful, right? So this is a little bit about prevalence. And what we see is that 21,000 of nearly 10 million youth between the ages of 13 and 25 were diagnosed with opioid use disorder between 21 and 2014. But then if you see it from 2014 on, although this isn't going there, but you can already see it from 2011 on, especially in that 21 to 25 age range, you see rising rates of opioid use disorder. And that's concerning. And then finally, you can see the third bullet, that overall only about a quarter of youth with opioid use disorder were actually prescribed medication-assisted treatment. And it seemed to increase with age. If you looked at teenagers who are 16 or 17, that number actually is less than 10%. So less than 10% of them get MAT. And between 18 to 20, it's about 22%, and rising to up to 30% when you look at that 21 to 25 age group. And then there are certain disparities that exist among even within that. medications are more likely given to white males and less medication is provided for other populations, females, African Americans, as well as Hispanic Latino populations, and certainly AIAN populations, right? So I think there are also disparities in who gets this. So I think especially for us as a state that is so diverse, something for us to think about and be mindful of, right? We've kind of talked about this. The main point here in terms of diagnosing opioid use disorder is that last bullet, that there are no separate diagnostic criteria for adolescents. So diagnostic criteria for opioid use disorder are the same, whether it's an adult or it's an adolescent, right? At the same time, it's important to keep in mind that many times our adolescents, and I think hopefully this is where we want to catch them, it says they may not meet criteria for moderate to severe opioid use disorder. Because this, remember, is a spectrum. People often start at the mild end of the spectrum, and if left untreated without intervention, it progresses to moderate and eventually severe opioid use disorder. And really, it's that severe opioid use disorder where you start seeing a lot of these consequences, right? Like health problems and social problems, things like that. So keep in mind that if someone has mild opioid use disorder, they may still be candidate for treatment to hopefully prevent this progression. So I think that's sort of the take-home point with this slide, right? So in terms of treatment, buprenorphine is FDA approved for individuals over the age of 16. By contrast, methadone and naltrexone, our other true medications for opioid use disorder, are both approved for individuals 18 and older. Buprenorphine, however, is FDA approved for 16 and older. The way you treat it is similar to treating adults. You can do in-home or in-clinic induction, just like we do with adults. It is recommended that oftentimes this population, the transitional age group, the youth, needs more intense treatment, especially earlier on, right, to help them engage in treatment. So maybe initially more frequent visits during stabilization phase may be helpful. There are some psychiatrists, adolescent addiction psychiatrists, who even recommend that for this group, and if you have the resources, I know it's a big if, but starting them in a residential or inpatient setting may be helpful to give them that initial structure, the intensity of treatment before helping them step down to an outpatient program. And keep in mind that oftentimes when we're treating adolescents, it's the entire family unit that we're thinking about. So encouraging family, as well as individual counseling by person experienced in addiction counseling, can be even more helpful in this population than when you're treating adults. Those are just a couple of differences that we think exist when we're treating adolescents as opposed to when we're treating adults with opioid use disorder. So now let's go a little bit to pregnant women, right? So what's the rationale? So I often start off the talk when I talk about pregnant women by bringing up the idea that opioids are a little bit different from things like alcohol or cocaine in that they're not directly teratogenic to the developing fetus, right? By themselves, they don't harm the fetus. It's really the withdrawal from these opioids that can be harmful to the developing fetus. In the first trimester, it's associated with placenta previa or even intrauterine death. And later on in third trimester, withdrawal from opioids is associated with things like low birth weight, prematurity. And then also think about our patient who's pregnant and using opioids. In my experience at ASAP, Vanessa, would you say at any given point, 10 to 20% of our patients are pregnant women, right? So in our experience, these are some of the most vulnerable patients that we treat. There is often history of trauma, complex trauma, houselessness. There is often, abuse or exploitation, all those things. So imagine how difficult it would be for this person to seek regular prenatal care when all of these things are impacting the health outcomes and daily life. So the idea is that first, if we get this person on a pharmacotherapy, we can prevent withdrawals, right? Because withdrawal can cause all these things like fetal distress, miscarriage, preterm labor. So if we provide a stable dose of medication, we can hopefully improve outcomes simply by doing that. Also, continued use, especially of IV injection drugs, certainly poses multiple risks. So if we can help someone cut down on that or even stop it, that obviously is of great benefit. But more than that also, treatment can improve prenatal care engagement, right? because oftentimes this is what allows this person to stabilize enough and have enough of that motivation to get that regular prenatal care and ultimately provide access to all of those other important things like parenting skills, food assistance, car seat program, and other community resources. A little note on New Mexico law. This has unfortunately really differed from state to state. There are still, even now in 2020, certain states in the country where if a mother who has recently delivered tests positive for any opioids, including methadone, for example, CYFD will get involved. Thankfully, New Mexico does better than that. This is what the New Mexico law states. Illegal drugs in mother's urine or the neonate's meconium or urine or unexpected neonatal opioid withdrawal symptoms does require reporting to CYFD. So if the patient is in treatment, if the mother has been in treatment, we generally, our patients don't have that problem, right? CYFD does not get involved. And really the idea is to encourage these patients to seek treatment to improve outcomes. For women who are stable in treatment and without other illicit substances present in urine at the time of delivery, there is not a mandatory reporting requirement to CYFD. So that's really what the law states. And really, in my experience, CYFD in New Mexico has really worked towards keeping the family unified and helping the mother seek treatment, as well as the family unit work towards healing, has been my experience. Right, so prevalence has been rising. This has really been reported. If we carry this out, this is going up to 2012, but if we carry this forward, the rates have continued to rise. And this has been reported in national data, that rates of neonatal abstinence syndrome continue to rise across demographics, right? Other things to consider. Women with OUD may present to prenatal care later in pregnancy and actually have less retention with prenatal care treatment. Many reasons for this. Fear of stigma certainly plays a big role. And also in these women, like I mentioned, complex trauma, sexual trauma is very common. And I do think that often plays a role in difficulty with seeking this care. You'd still use the DSM-5 criteria to diagnose opioid use disorder. When you do interview this patient, right, it should include substance use patterns prior to and during pregnancy, because this is certainly our experience that many women make a very sincere effort to reduce or limit drug use when they discover they're pregnant. So in terms of getting a full history, you might find that right before pregnancy, before finding out that pregnancy was there, the use may have been higher. Many women with OUD also use tobacco, which is a proven significant fetal risk. So just be mindful of that, right? To always ask and provide cessation resources if indicated. Moving forward, right? So a couple of thoughts in terms of treatment, right? If you're going to use buprenorphine, keep in mind that still in 2020, the standard of care is that for pregnant women, we use the buprenorphine only formulation, which the brand name is Subutex, but it's also available as a generic. So we do use so if a patient has been on the combination buprenorphine naloxone, we just convert her over to the mono product for the duration of the pregnancy. You generally don't need to adjust the dose. The dosing stays the same, and post-delivery, you go back to the combination product. Now, this should say naltrexone. I apologize. Naltrexone is not approved for use in pregnancy. That being said, there are small case reports starting to come out over the last couple of years where clinicians did use naltrexone during pregnancy, and the outcomes were actually acceptable. But we don't have enough data for us to say that that's the standard of care right now. Use the lowest dose that manages withdrawals and craving symptoms. Finally, the role of counseling, right? In education. Oftentimes when I work with pregnant women, there is this great concern about what's going to happen, concerns about opioid withdrawal symptoms. And one of the things that I really be sure to emphasize is that you're doing exactly the right thing. If you go to SAMHSA, there are some good brochures. There are public domain that can be given out to pregnant women, little educational brochures. But I think that's the main message, that you're doing exactly the right thing. Because there might be other messages coming from a significant other, from family, from friends, that why are you getting treatment? You could be harming the fetus, right? You could be harming the baby. So I really try to tell them that the goal right now is to get you on a stable dose, keep you comfortable, because if you're comfortable, the baby is comfortable. And if you're withdrawing, the baby is withdrawing, which is what we don't want. So I'm really sure to emphasize that, to make sure and encourage our patients to get to a good dose, a therapeutic dose of the medication. I also tell them that dose isn't necessarily related to neonatal abstinence syndrome or the neonatal withdrawal. It's not predictable which infants will be affected, right? Also, there's minimal risk of long-term developmental problems for the child or the infant if they're receiving medication-assisted treatment for opioid use disorder. And we also address pain management, because often that's the other concern. If I'm on buprenorphine and if I need a C-section, how will my pain be managed? So we also address that there are many things we can do. Here it mentions epidural analgesia, and that's often something we do. There are also methods emerging where you can continue someone on buprenorphine during the procedure and augment with other medications. So we talk about a lot of those things, and that's important to do. Next, we'll touch base, and I'm just gonna look at the time here, make sure I have enough time. That's not my phone. Oh yeah, it's 12:24, we're good. We're gonna talk briefly about breastfeeding women. So breastfeeding, the main point is that it's actually acceptable and encouraged if the patient is being treated with either methadone or buprenorphine. We in fact know that breastfeeding shortens the length for neonatal withdrawal syndrome and decreases the medication dose requirements. Kind of cool, right? Things like early breastfeeding or sort of rooming in of the baby and the mom, skin-to-skin contact, all those things seem to help with the neonatal abstinence syndrome in the baby. It improves the bonding, certainly provides optimal nutrition for the infant, and improves maternal self-efficacy. And there is minimal transmission of buprenorphine through breast milk, and there is no risk of neonatal oversedation. So as long as there are no other contraindications, we tend to encourage breastfeeding post-delivery, right? And the other key point, of course, mothers should be transitioned back to buprenorphine naloxone, that combination product, as soon as possible, ideally by 6 weeks postpartum, because it has lower potential for diversion and injection use. Screening for postpartum depression, critical in this population, because up to 40% will screen positive, right? Extra pearl, THC, does pass through breast milk very readily, and its effects on brain development are unknown. So I know THC use is very common amongst our patients, but it is important to talk about.
I think that might be
and right now, the recommendation from ACOG is to recommend against breastfeeding and from AAP if the mother is using opioids. Sorry, where did it go? Why is it not progressing? Now it should work? Okay, got it. And last, medically comorbid populations. ACEs. I'm gonna start just with you guys have, many of you have probably heard this. I'm gonna start just by really bringing up this idea that there is often a shared etiologic pathway, which is the ACEs or adverse childhood experiences, right? So very often, these are things that someone experiences very early in life, right? Whether it be abuse or even things like neglect. And things build upon it, such as social, emotional, and cognitive impairment, adoption of health risk behaviors, which can include, right, things like substance use disorders and ultimately many diseases and even mortality, right? So there might be common etiologic pathways related to early trauma, related to early neglect, that unfortunately have pretty significant implications in terms of the overall health, right? Some of the main things we talk about, infections. HIV does vary regionally. We here in New Mexico tend to have fairly low rates comparatively of HIV in this population. But still, there's clearly an increased risk of HIV with injection drug use. Hepatitis C, extremely common. Overall, nationally, up to 80 to 90% of injection drug patients with injection drug use will develop hepatitis C in their lifetime. Other medical illnesses, right? I brought up, things psychiatrically, about 2/3 below PTSD is very common, also anxiety disorders, depression, sleep disorders, chronic pain. Well, maybe not a surprise, but present in, here it says half of people, but in some of the newer data coming out by SARE out of California, up to 2/3 of patients with opioid use disorder report chronic pain. And for a majority of those patients, actually chronic pain tends to come first, and opioid use disorder seems to develop later. Similar rates for diabetes and hypertension, but certainly access issues. Higher rates of COPD, right? Majority of patients on buprenorphine or methadone smoke. So I think smoking cessation is certainly very important to address with this population. Oh, I think I'm unable to advance again, sorry. Stuart? Okay. For patients who have a lot of medical comorbidity, keep in mind that buprenorphine is safer because of less respiratory depression as well as fewer drug-drug interactions. It generally is pretty safe, right? I've listed some of the more common drug-drug interactions here, but certainly compared to methadone, which interacts with just about every medication, it seems, buprenorphine is a lot safer to use. Some of the other pearls, right? Treating with buprenorphine if HIV or TB are present. Consult with an ID specialist if possible before prescribing. Ideally, you can treat these concurrently. If co-occurring mood disorder, prescribe normally. If COPD, hypertension, diabetes, prescribe normally, but of course treat those other things. In case of tobacco use, be sure to encourage cessation and to provide resources. So I think this is just, we'll end here with some references, and I think we're right on time. So we can do maybe 1 or 2 questions and then turn to the case facilitations.